response that I got, and I'm like, I need to get with the program.
Oh my gosh. Well, you don't even have to do that. Like just do a Google search and it automatically uses the AI, which I have to admit, I do find helpful a lot of times.
Yeah, I think the scary thing for me is when an IT director at an agency looks at you and says, you need a policy on what? Hold on 1 second, and types it in, and you go, oh, oh my. And in 4 minutes, a 10-page policy spits out. You're like, holy moly.
It's, yeah, kind of
Mm,
amazing.
it will rule the world.
Hey, Joy. I was hoping you'd be here.
I'm glad to see you, Laura, always.
Me too. Me too. Here's my team. I was telling everybody it's Zoom, so I have to get on early to make sure.
So we're still waiting for quite a few board members too. So we'll wait it out a couple minutes.
I'll have my camera on soon. I'm just maybe about 5 minutes away from my office. Sorry about that.
No, you're good. No need to apologize. I know we're not going to have Dr. Rice. She's out at a conflicting meeting this morning. My brain is not working. Who just emailed me? Katie's not going to join us. Let's give it one more minute. There's Jen. All right, I say we go ahead and get started. So I turn it over to Jen.
Good morning. Happy Monday. Um, just looking at our folks on the call. 1, 2, 3, 4. Do we have a quorum?
Don't think we do. Let's see here. 1, 2, 3, 4, 5, 6. I think we're still below quorum.
I can keep
Like
an eye
7.
on who comes in and see if we get one as we go, if anyone pops in a minute.
Okay.
I'm counting 7 now. How many total members do we have? 14?
Oh, there's Samantha.
All right, now we have quorum.
Yay. Okay, perfect. All right. Do we want to go around the room? There's not a ton of us here. I know we have a few guests. Starting with, I'll start. Jen Vasquez, I'm the board chair. I represent, oh, my seat has changed. It used to be hospitals. Now it's, remind me.
Oh, you are asking the wrong person.
uh, I think public sector, maybe. Michelle?
I'll have to dig for the thing.
Hi, my name is Michelle Muthing, and I'm the vice chair, and I represent the public sector.
Joy?
Morning, I'm Joy Hart with the Behavioral Health Administration and just a friendly observer and supporter of MCAV.
Thank you. Kevin.
I'm Kevin Bishop. I am just a visitor and hoping to learn. And I'm one of the chairs of the Crisis System Subcommittee of the Behavioral Health Task Force.
Okay, thank you. Dr. Simpson.
Hi, good morning. Scott Simpson. I'm a psychiatrist and I'm the director for the Division of Community, Population, and Public Mental Health in the Department of Psychiatry at CU. And I am here in my role as the CU Health Campus representative.
And Samantha.
Hi, I'm Samantha Garrett. I oversee legislation, policy, and budget for the Office of Civil and Forensic Mental Health, and I am here on the CDHS seat on the board.
Thank you. And Joy, I already did you. Jess.
I'm Jessica Bell. I'm the Associate Director for 2765 Services, and I represent BHA on the board.
Thank you. Donna.
Donna Casey, Director of Accreditation and Regulatory at Children's Hospital Colorado, representing Children's on the board.
Thank you. And Kelly.
Hi, I'm Kelly Konkowicz, and I'm representing the family members of consumers of mental health. I had a daughter who had severe mental illness.
Did I get all the board members?
Hi, everyone. Casey Wolfington. I'm VP of Behavioral Health with Vail Health. And I think I represent rural hospital systems, but I don't remember exactly what I represent either. So, Jessica, if you find that paper, let me know.
And I'm Sean Hansen. Professionally, I work at Denver Health as a biostatistician and data scientist, but I am here in a personal role as a consumer of mental health, as my representation on the board.
Perfect. All right. Oh, perfect. There we go. Proprietary skilled health facilities. That's what it is.
I don't think I have everything on one page. Well, it's one page, but we can't quite see it. Now it's really small, but there's the whole list.
Awesome. Thank you. All right. Shall we review the agenda? Any additions to our agenda today? All right, if not, let's go over January minutes.
I will just scroll until somebody tells me to stop.
Okay. All right, any adjustments, additions, questions?
I move to approve.
Okay, I'll second. Did we hear back from Ryan about officially removing the person that wasn't attending?
We have not heard back officially, but I can either Joy or myself can follow up with him. I know he's elbow deep in legislation right now.
Yeah, definitely. That makes sense. And then just one other comment on January's minutes. We talked about discussing our next in-person meeting. Do we want to look at the calendar? It looks like March's meeting is what, the 9th? March 9th? And then April 13th. Do we want to maybe look at one of those being in person or hybrid? It's been a very long time. I feel like it's been over a year since we met in person, right?
Something like that. I'd like to throw out April as the option, just given March tends to be really snowy, and I know we've got
Yeah.
people that would have to travel.
Yeah.
What would be the location on that?
Up for conversation. Did we ever get, I know several months ago we talked about travel reimbursement. Did we get final information on that issue?
That is a Ryan question also.
Okay.
I got my certificate in the mail on Saturday
Yay.
to say I was appointed 3 years ago.
Wow.
They must have sent them all at the
I know,
same time.
I know we talked about people not getting letters. I know we had mentioned, wait a minute, we're supposed to get paid. What? And all of a sudden this certificate shows up on Saturday.
I was thinking about that with the people
Never,
running it too.
Michelle.
It's like if everyone got a giant certificate, maybe they should be coming now.
Did we ever hear back about getting paid?
That was another Ryan question, I thought.
Yeah.
Yeah, it's a
Ryan
Ryan
is the
question.
holder of information.
I
That's what
mean, I
happens.
think April sounds great and I'm up to go wherever. I just don't really want to personally shell out hundreds of dollars for travel expenses if it's going to be somewhere far enough to have to stay. So yeah. Looks like Dr. Simpson said maybe Ann Schutz. I would love to see university. I work with Amy, the social worker, all the time. So, I mean, if anybody else has any other suggestions, otherwise maybe we look at university. Yes.
Yes.
How about I send out a, what's that called? A Google form. And if we have enough interest, making myself a note, sorry, just one second. So maybe tentatively at university on April 13th.
How many people, Jen?
I mean, there's what?
We have 14 members. So
Okay.
like maybe up to 20 for those few people that
Sounds good.
routinely join us.
Is it possible to get a tour of, probably due to HIPAA reasons, we can't go on the unit, but maybe take a peek at the inpatient area?
Let me work on that.
Okay.
Yeah.
So if the meeting is 9:30 to 11 and then maybe another 30 minutes or so to converse, similar to what we did last time when we were at Fort Logan.
Sounds good.
Well, actually, no, we decided if it's in person, we were going to do 2 hours, right?
Yes, but we've been pretty low on the list of agenda items. And so I
Okay.
don't know if we will have the full 2 hours for an in-person. But who knows? I mean, part of our discussion today is going to be what do we want to focus on for the next
Yeah.
That would be a really great meeting if you're in Denver to be able to invite our hospital people for that hospital conversation. If we can figure out who.
Yeah, and I was not able to get that discussion with my team, just given a lot of the things that have happened in the last week. We had quite a robust team agenda. So that was something that kind of got pushed to our next monthly meeting. Unless we feel as this group that that needs to be prioritized, and I'll look at my team's calendars and put some time on their calendars to discuss it sooner.
And we're talking the April 13th meeting, yes?
Mhm.
Okay.
Okay. Moving on to secure transport.
I just muted myself. I was trying to get this to open, and I don't know. Sorry, this thing like is in the way. This is really the only bill right now that's impacting 2765. And so I don't know how much people know about it or what their thoughts are on it. It's really just a slight change to how we use secure transport. Where is it? Sorry. So it's really that we would rely on secure transport whenever possible instead of law enforcement. So as you can see, we have several different legislators sponsoring this, including Senator Amabile and Representative Wyden, who do a lot of the behavioral health bills and sponsor them. So this is House Bill 261063. There's going to be a lot of different things in this bill. The ones that will impact us the most, like I said, is around secure transport and how it just makes some changes to like the emergency mental health hold, and it makes some changes around like the pickup orders using secure transport. The big one that doesn't impact us directly, but will have a bigger impact on the entire system is the proposal that CDPHE take over licensing of secure transport and take that back from the counties. So I'm not going to go through and read everything or read really any of it, but it is here. If you can't get that link in the agenda to work, more than happy to put the link in our chat or answer questions. So you
Can
can
you
see
put it
that.
in the chat, please?
Yes. Let me know if that one doesn't work.
And Jessica, I guess I don't know. I'm curious why CDPHE versus BHA.
Above my pay grade.
Are there like, yeah, I don't get there logistical benefits to that, or what are?
Erin's got her hand up. She might know the answer.
I actually do. So Kevin and I have been working on this bill with the BHDC JJS task force and subcommittees. So when secure transport was originally created, our understanding from talking with folks was that they were trying to mirror the ground ambulance licensing process, But at the same time that secure transport was being created, ground ambulance licensing went from the counties to the state, but they didn't at the same time then restructure secure transport to state licensing. And it's been kind of a challenge for counties to stand up these programs to license secure transportation. Agencies have found it difficult to get licensed because they need reciprocal agreements to work across counties or be licensed in multiple counties if they're picking up all over the place. And so this was an attempt to kind of streamline that process, create some consistency, a single point of licensing for the providers, as well as an opportunity to have a list made available for consumers and facilities of who those licensed transportation providers are across the state. And right now, since it sits with the counties, it is nearly impossible to find a list of who those providers are. So that was the conversation that happened around that piece. And BHA doesn't license transportation like that, so it made more sense to put it with CDPHE combined with the ambulance service.
So glad you're here, Erin. But you can see as I kind of scroll through here, most of it is just refers to defaulting to secure transport instead of relying on EMS or law enforcement to transport.
I do not know why that link just does not want to work. Okay, let me just go to the website.
Well,
Interesting. That's interesting.
What if I do this? Let me know if that works better. Because then okay. I say then you can just click on the recent bill PDF.
Thank you.
Yep. Close some of these tabs down. That's really all I had for secure transport. And we kind of did the inpatient discussions update. So it's sounding like because we want to invite some people to the April meeting that I should probably prioritize that meeting sooner than later. So I will do that. I will look on my team's calendars and schedule some time to talk with them about who's the most appropriate person to have that conversation with at their different agencies that they license.
Is there a sorry, back to the bill real quick. Is there a document that exists in someone's computer that lists the secure transports licensed in the state by county? Do we know? Do we know how many are in the state? I would assume if someone put forth a bill, it's because they have this information. Does it exist anywhere? Does anyone know?
Do you mind if
I only know my community, so I'm just curious what the state looks like.
So that's part of the problem, Michelle, is that it is darn near impossible to get a list of who those providers are. There used to be one, I think either CDPHE or HCPF had a list at some point, but keeping it updated was a challenge because HCPF only had the ones that were approved Medicaid providers, and CDPHE didn't really know who all of them were because they were sitting with the counties.
And it's so because it's held by the counties and not state that.
I have a list of what I know for some work that I've done, but I would not even suggest that it is comprehensive and they change. So that is part of something we're talking about being important with this bill, is that there will be a list and that information will be available for folks to know.
Fascinating. Okay.
I think the other thing, oh, I'm so sorry. I think the other thing that's real haphazard across is just, I think there's obviously clear understanding of Medicaid, for the secure transport when it's a Medicaid patient funding wise. But what I've also seen is billing and cost varying dramatically across the various counties that are coming to our inpatient facility. So just maybe thinking about maybe this group wanting to encourage some streamlined pieces there as well.
Yeah. That's important, Casey. Thanks. Yeah. Forgot about that. Dr. Simpson, were you going to add something?
I don't think so, but
Oh, I thought two people were talking at once. I just
I'm
wanted to
sorry.
say.
That was me. I had started to jump in to try and
Oh,
answer
Kevin.
your question, but that, I mean, I don't know how many people here were involved in all the discussions about it last year, but uh, we had a lot of discussions about the fact that nothing much is known about the licensing and whether licenses have expired or not. Nobody could tell us that anybody was keeping track of, somebody who was licensed today, whether their license was expiring tomorrow, if they were going to continue to provide services despite not having a license, et cetera. So there's no regulatory kind of oversight or looking at things in any kind of meaningful way because it is so broken up amongst the counties, and all the counties do things quite a bit differently. There's some areas where counties share uh, like kind of areas and contracts, um, but it's not uniform, and so people have to get licensed in multiple counties and pay multiple fees, and nobody's keeping track of how that's going or providing any training, which is, well, I can't say not providing any training, but it's hard to say what the training is.
Any other questions, comments, concerns on the secure transport bill? So I will keep you updated. I keep an eye on the Ledge website pretty regularly to see if there's anything for 2765. I have a couple on my desk right now, but they're not public facing yet, so I can't share them. But if they become public facing, I will definitely let this group know. Go ahead, Kevin.
Jessica, I feel like I saw one, and I am frustrated that I don't have the number ready. But one where it would combine ECIC holds that came out, and I was curious to hear about that.
I have this. I have all kinds of stuff.
I say, what number is that, Samantha?
That is, it has been introduced. It is House Bill 26-1116.
Thank you.
Process for people with behavioral health disorder. So it doesn't actually amend 2765, it amends 2780, but one of the goals is to put those mental health hold processes in alignment.
I know that was really one of the things that was important in this group conversations over the last year too.
Do we want to talk about it? I mean, well, it doesn't. Sorry, go ahead, Samantha.
I just said 2780, but it's 2781. Clearly, I'm not up on my SUD ledge.
Well, I mean, I get it. I mean, we gave some pretty specific feedback on this one, so I don't know where that stands. I'll have to follow with Ryan yet again. But it basically copy and pasted 2765-106 for the emergency mental health holds into 2781-111. So it's an interesting proposal, is what I will say.
26-11-16, you said?
Yes. My biggest concern with this one is continuing to use gravely disabled, but now we're describing it as substance use. So it's still gravely disabled, but defined in two different ways in the same title.
So we're using, sorry, am I understanding that you're saying the term gravely disabled now has two very distinct definitions?
In two different sections of the same title under behavioral health.
That's a mess.
There's also, I think, new legislation to update gravely disabled to include anosognosia and a few other things. So there's, and I don't know if that bill's out yet, but I know that there's discussion about changing some of that wording anyway.
So, so does this mean that in the 2765 statute, when we look at M1 holds, gravely disabled is going to be due to a mental health condition, but gravely disabled under the what used to be the 28, whatever, 111 is now going to be gravely disabled due to a substance use.
Yep.
Our poor physicians are going to be lost. They're not going to understand.
This definition of grave disability is also going to be like time sensitive, right? Because it's like being under the influence as opposed to like a long-term grave disability resulting from long-term substance use.
So I know in the gravely disabled for the mental health, it already includes deterioration. And the substance use one does as well. I think the problem is that doesn't get actually emphasized with physicians enough, that this, or with law enforcement or anyone else, that the grave disability should include the likelihood of deterioration. And it doesn't. It's always immediate. Like if you're only a danger to yourself or others if you're holding a knife and, ready to kill yourself. As soon as you put the knife down, suddenly you're not gravely disabled anymore. So I'm like, the threat to self or others is a problem in and of itself. And I know that that's one of the things that some of the changes are trying to look at from hearing a lot of other conversations.
Anyone have any other thoughts on this particular one? I'll dig through the legislative website and see if I can find that gravely disabled one. But yeah, some of our feedback around this was that gravely disabled, and hey, that's going to be really confusing. And how can we, if we're going to move down this route of combining substance use and mental health anyway, what's the best way to do it? Has been kind of our feedback. So we'll see where this goes as it goes through committees and hearings and whatnot. But it is only 23 pages, so this is a good one to spend your time on. That's what I would say. Anybody have anything else for legislatives? Anything that you know of that I'm missing?
Well, sorry, just one other quick thought on this bill. Yeah, I mean, it's kind of interesting. I mean, the EC process is always like a little quirky and hyper local in how it's used. But I guess one thought I have is a lot of the facilities that'll accept ECs and especially involuntary petitions don't really have the capacity to manage the severity of like disability that's being described here. So, and I think that the BHA's approach, has been that, hey, if people are too sick for the EC process, they need to go on a mental health hold 2765 process. But so that is to say that, I mean, I don't know how this would play out in real life, but just from a practical standpoint, I don't know that you could actually leverage this for patients who are gravely disabled, quote unquote.
Samantha?
Yeah, I was just gonna say that the competency bill, which has not been introduced, but has been drafted and the draft has been made public for stakeholder feedback, makes significant changes to 2765. And that's probably something we should touch on. So if anyone has not seen the draft of that bill, I can share it and tell you where feedback is needing to go. And they're asking for feedback by close of business on the 13th, this Friday. It is a 212-page bill. So this Friday is soon in that context.
Can you say that bill number again, please?
It does not have a bill number yet. It hasn't been introduced yet.
Okay.
I can see if I can upload the draft to chat or something. The draft has been distributed just by email. I will say it was drafted by a collaboration between the Colorado District Attorney's Council and the Office of the State Public Defender. Without expressing an opinion on this fact, I can say as a matter of fact, that means there were no providers engaged in the drafting of the bill. So provider feedback may be particularly useful at this stage. I guess I'm not allowed to say what would be useful, but there hasn't been any provider feedback yet. There's a lot of politics on this one, friends.
I'm glad you're saying all of this and not me.
I mean, the governor supports the bill. I do not have anything to say other than that when it comes to how you should feel about the bill. It does exist. I am allowed to share it.
I'd love to see it.
As someone not involved with it or concerned, I would also just say that it seems like a provider perspective could be really useful to taking a look at the bill and seeing kind of how you think it would work. And that would just be a request on my part too. Or not too, but it would be. Leaving Samantha out of it.
Can you summarize? Sorry, I apologize profusely. I've been multitasking as you're talking and pulling up these bills just so I have them marked. And can you just run through again which ones you talked about? 26, 11, 16, 26, 10, 63. I may have written that down. What was the other one?
We talking about the competency one? That's the one that doesn't have a number yet.
The ECIC thing.
That is,
I think I missed that one.
That's this one. The 26, 11, 16 is the
Oh,
ECIC.
okay. That is that one. Okay, then I got them all. Okay, we're good.
And it looks like Samantha did drop the PDF into our chat.
Beautiful. Thank you, Samantha.
I think well, if I just about the competency bill, for folks who are looking at it, since it is so large, the first half seems to be about process and court process, legal process, etc. The 2765 portion kind of comes midway through, halfway through, and is important to find good solutions for some of what's being proposed.
The competency one, that PDF that was just dropped in, is this the one where they talk about merging the EC and the IC?
No.
Okay. So what is that one? Oh, that's the 26, 1, 11, 16. Okay, never mind. So sorry. I'm right. I need another cup of coffee. I got it all.
Oh, and Frank dropped in the flow chart. Fantastic. I was going to ask if anybody wanted to share that one as well.
The flow chart's really helpful. It clarifies a lot of the, because that bill is huge.
It is really big. It took me, I'm still in the middle of it. And I'm still like trying to piece together like what the original bill, not the original bill, the current statute says. And like, okay, so if I go in here with this and like kind of making those connections, it is slow going because it is so big.
The flowchart is also very focused on the experience of criminal defendants moving through the system and does not really look at the flow of like civil 2765 processes, which are also changed by this bill.
I think that was actually why the bill was proposed, was because there was a problem with people going through competency and then being released instead of going into civil or going into purely forensic. So that's exactly what the bill's designed to do, I think. At least that's what Judy said.
Yes, that is exactly what the bill is designed to do. and it's going to have a lot of ripple effects throughout all of 2765. So
Right.
especially since like the drafting was then experts on the competency system, like no one who is expert in the civil system was part of the drafting. So there's going to be consequences within 2765 that people who live in 2765 should look at and think about.
Was that purposeful, accidental, an oversight?
I am not at liberty to answer that question. Also, I don't know. I was not involved in the ultimate drafting of this bill.
So sorry, I was flipping through. What's a good way to provide feedback on this? Would you like, I see that there's an email list for a number of legislators, or would we do that centrally through this group? Which I guess begs the question, if we have feedback on the other bills, how should we go about compiling and sending that out?
I'm gonna look to Joy, who's on at least BHA's ledge team. I know all of my feedback, because I'm part of BHA, goes to like Ryan and his team. I don't know how else you would do it as a member of the public or member of this board. We've never really had that process set up. Samantha did put in the other bill sponsors that are getting the feedback. The Julie McCluskey, all of the legislators that have sponsored that, it looks like, need that feedback by close of business on the 13th. And so when it's like at this level of stakeholder feedback, is that what it's called now, Samantha? Even though, you know, providers weren't in it, but it's like, this is where the feedback is for the public. Thanks, Samantha.
Yeah, and that's exactly, so like the email that initially sent it out to like the stakeholder group that originally got the draft asked for feedback by section by close of business Friday, sent to everyone that I sent the email addresses for. So if you have feedback, send it by email to that list of people, and as organized as possible according to the parts of the bill, because it is very big.
Samantha, do you know when it's scheduled to be introduced?
I don't. I imagine that may depend in part on what feedback they get this week, and how much they want to look at changing the draft based on that feedback. If everyone's great with it, then I will imagine it'll be introduced very soon. But it is very long, so if there are changes that need to be made, that process could take a while.
Any other bills or things from legislative session people would like to discuss? All right, we can move on. Michelle brought this up, and this is why we have all of our DOC folks here today. Michelle, would you like to introduce what we're talking about?
Yeah, if you put that agenda back up so I say it similarly. How did you word it?
Just DOC parole. We talked about that there was some need for aftercare and mental health services.
Yeah, being able to provide folks. This is kind of a big topic. However, when folks are released from any form of incarceration, their re-entry back into the community in many places is so very limited. And curious what places or agencies have in place, I suppose, for this, and what are the gaps, things that we might be able to talk about. I know one of my biggest frustrations in the world of crisis is this whole HIPAA issue, where we can't talk about stuff because of HIPAA. The judicial system has a little bit of a different piece of the pie with that. But the bottom line is we need to be able to connect people, catch people, and in this case, for more than one reason. And so I think I'm just curious what is in place, and what entities might do in specific areas, because again, I think like much of what we've talked about, it's not always consistent. Did I miss anything else I said to you, Jess, about this?
Nope, that all sounds correct to me.
Okay. So I was just curious.
And to clarify, Michelle, you're talking about individuals who are on parole, so they're in some level of community corrections.
Or not.
Okay.
Some are just released back into the community. So for example,
Yeah.
We had a guy who, I love that warrants no longer trump needing inpatient. So I can show up with my law enforcement partner and they can say there's a warrant out for their arrest, and they will step back if it is a warrant that they believe they can sidestep so that psychiatric treatment can come first, right? They kind of have that discretion. However, we had a gentleman who we put in inpatient, desperately needed inpatient. He came out, went home. There was a warrant out for his arrest. He was arrested, and incarcerated. But when he came out, there was no communication, and he ended up decompensating again and right back into the middle of the muck pile. And so I think this is one of the two prongs that if I could wave a magic wand and we solve these issues, I would love to, because as a crisis clinician, I send someone to an inpatient facility and have no idea when they're discharged back to the community to catch them and be able to connect them. I think discharge planning is mediocre and sporadic at best, depending on what hospital you're talking about, what community people are going back to. But this is the judicial side of this. Someone has a psychiatric issue, is incarcerated, and when they're released, they're usually given a parole officer. But I have no idea what that world looks like with them getting back into mental health treatment so they don't end up reoffending and back in jail or end up back in a facility. So I'm just curious what people have or know as systems, if anything, processes. In my experience and the conversations I have, there aren't any. So I'm curious.
Trying to figure out how to raise my hand, but
Laura, I was gonna just jump in a little bit, and
sure.
the complexity of the judicial system, because Michelle, what you could be talking about is parole legitimate coming out of a DOC incarceration or sentence. Then, the DOC's got that pretty well covered in a lot of different ways and had to create their own systems because there weren't any, really established and wanting to work with this releasing population. And then I think where it's even more problematic or troublesome, to your point, Michelle, is that coming out of a county jail or a detention facility, that they may be there for temporary charges or brought in, but they could be coming out on probation, which is definitely different than parole, and or no type of supervision at all without having any charges being dismissed or still pending or whatever that may be. and still not having any type of community supervision or support. So there's, the environment that they're coming out of is really a key to know about. To your point, Michelle, like even coming out of a psychiatric facility off of a emergency hold, the communication for transition of care is problematic. I mean, it really is a problem. But to DOC and parole in particular, I think Laura Kale, if you want to go from here, that you guys got to cover.
Thanks, Joy. So my name's Laura Kale. I'm the Community Behavioral Health Administrator for DOC. I work for clinical services, but I have a team situated in the parole division and in parole offices. We have 8 clinicians. We have 8 licensed clinicians that are situated throughout the state that provide essentially transition care for those with serious mental illness and those with dual diagnosed mental illness and substance abuse, high substance abuse needs and high mental health needs. And so we're providing, we're identifying those that are coming out onto parole, and then identifying what their needs might be in the community, working on those transition plans for mental health services in the community. And then once they're in the community, we're providing supports and working with parole officer, working with a lot of other parole staff on helping them get stabilized and getting connected to those community resources. I've got Michelle Long here. She's our supervisor, and Havesh Lachman is one of our parole behavioral health clinicians up in the northern area. So I don't know, Michelle, if you want to talk a little bit about anything that I may have missed, or what kind of prompted us to jump on this bandwagon here.
Yeah. So we were actually in a meeting with Jen Vasquez. She was kind of meeting with our team to so that we could learn a little bit more about Fort Logan. And in our discussion, we were sharing some of the gaps and some of the challenges that we're facing as parole behavioral health, working with, kind of our highest acuity folks that are incarcerated and trying to transition and bring them out into the community. What we're finding is that really, I mean, these folks are essentially at an inpatient level of care, and we're transitioning them out into an outpatient level setting, and it's just not really appropriate. We just don't have any other options for them. So we're finding it even with like the mental health transitional living homes, like we have a lot of folks that are on involuntary medications within the prison system. Those involuntary medications do not follow them out into the community setting. And so a lot of times they'll release, but because they're on involuntary medications and they haven't been taking medications voluntarily and compliant for 6 months, they are not eligible for a lot of the other resources available in the community. So essentially, we're transitioning those folks into kind of an outpatient level care setting, and it's just not, they're not successful in trying to do that. And so I think we were trying to figure out, especially for our folks, at San Carlos, which is kind of our inpatient level facility, how do we go about transitioning them out into the community in a way that would really meet their needs. We do a lot of work on the transitional release planning, like Laura said. We have psychiatric and MAT inreaches set up, which is where we're connecting them prior to release with outpatient providers, getting that initial intake done, getting community appointments set up, and supporting them in that way so that the transition of care and the care coordination is kind of happening pretty fluidly. But we do struggle with bringing that high acuity population out into outpatient level care.
I bet. Dan, did you have your hand up?
Yeah, thank you guys. Excuse me. Nursing the tail end of the flu. So sorry if I'm hard to understand, but I can tell you from kind of personal experience. I was a parole release case manager for Sterling Correctional Facility. So I dealt with the guys that were leaving 180 days out. I remember on several occasions where Michelle and I and her team would talk about, higher acuity clients. And I can tell you from experience, like a lot of the problem that I saw was definitely the continuity, right? From my perspective, I mean, let's face it, the sheer volume of people being released from the different facilities is overwhelming the system, just as a root cause. So being able to try to find appropriate facilities in an appropriate time frame is one challenge. Um, and at the same time, right, the that machine is turning. They're leaving the facilities, and we're not stopping that at all, especially with the new challenges that are going to be coming up for, 26, 27 for the state. Let's just face it, for us on the other side of things, like I'm in ComCore now, and we're going to be pushed to take more and more. Now it's easy for us because we can do inpatient, outpatient. That's fairly seamless. But what happens when we're at capacity? And now we're pushing this off into other facilities. And in my role was to get, I mean, housing, employment, and other stuff. Mental health was at probably the lowest. And that sucks, especially from some of these clients that I'm telling you, even at a year, they need some kind of transitional help. And as much as we liked to have prepared them the best we can to go back into life in the community, guess what? It's just impossible to replicate or mimic the community in a prison setting. So, it's more of a life skill kind of thing. But I just think of the sheer volume that we're coming out with and the places that they're going. You have to remember when we were looking for places for them to go, we're talking, whatever the we could get past. If that was an uncle and parole did a housing visit and said, "Yep, he's good to go." Guess what? Didn't matter what his mental health care was needed, right? He's going to his uncle's house. If it was sober living, okay, good. We might be able to get away with that. But sober living didn't really have the impetus to follow through with any kind of care. And of course, at that point in time, these guys are ready to get out. So, their mental health status is not really high on their own priorities, right? So, yeah, there's a lot of gaps in that. And is the best, I mean, DOC did the best they could with what they had. But the reality is that they're just the sheer volume of it and the sheer, I guess, the importance of it falls off once they walk out those doors. So, my feeling is those are the two gaps that we need to look at.
I'd love that. Thanks for sharing, Dan. Kevin?
For both Dan and Michelle, I'm really curious about whether you see the issue really kind of being mainly the parole population, or is that a portion, or what portion of the entire group of people who have either killed their number or whatever, who are in need of services? And um, is it bigger than just the parole eligible folks?
So our team serves even sentence discharge folks, and we can provide services and support to those folks for up to a year post-discharge. So if they are sentence discharged, that means, like you said, they killed their number, they are not on parole. We're still providing services and support to those folks. We're still offering those in-reach appointments, doing continuity of care. They are coming to the parole offices and working with us if they choose to. Some of them do, and some of them don't want to do that. But I think the other piece too is that, we're not just transitioning their care out into the community to an outpatient level, but a lot of these folks, they are not eligible. They're not being accepted into sober living programs or transitional housing. They're really coming out truly homeless or in shelters because they aren't they don't qualify for the programs that are available in the community. So we're not just transitioning them out to outpatient care. They're actually coming out with a lot of times no housing, or the shelter is the best that we can do.
That's helpful. I was curious about it sounds like you've answered one of my questions, which is sort of like the either perceived or mandated responsibility to continue it for folks who've like finalized and killed their number too. And it sounds like you guys also are available, at least for folks who are open and willing to be like stay engaged with DOC for that.
Yeah, and that's not just Pearl Behavioral Health. We have our community reentry specialists. They are also able to provide service and support to those individuals for up to a year post-discharge as well. So they have, the community reentry specialists and then Pearl Behavioral Health support if they choose to engage with us. And we try to work really hard to get them to engage with us before they leave. We're meeting with folks before they leave and really encouraging that. But a lot of times they don't, and they're not on parole, so we can't really, do much about that.
I think the distinct difference, Kevin, too, is somebody who's attached through parole and has had those eyes on them, whether it's a parole officer, community reentry, parole behavioral health. There's usually the whereabouts are known of those individuals, but it's that pre-adjudication or, coming out of the jails that just they tend to be in limbo of systems because they may be brought in for one reason or another, and no knock against probation, but they just have a different level of supervision efforts and abilities and connection and communication to the services in the community. So I think that there's a distinct difference again, like what system of sorts are the justice involved individuals that we're talking about. And then we don't even want to get into community corrections because that's like a whole level of confusion. But yeah, because you can have parole in a community corrections bed, and that's, another story.
Well, and one of the things that we didn't mention is that we're not just focused on the release planning. So once they are out and they're on parole, we're teaming with the parole officer who is in charge of that supervision, and we're supporting those clients throughout the duration of their parole as it's needed. So if they're struggling, if they deteriorate, if they have an inpatient stay, we're contacting those inpatient facilities. We're supporting that discharge planning because we too have concerns about the discharge planning piece and making sure that that's solid and that they really come out from that inpatient stay and re-engage in community care. So we're tracking those hospitalizations, we're supporting the client, and we're trying to team up with those facilities. Same thing happens when they cycle sometimes into the county jails and out. We're trying our best to collaborate with the county jails. A lot of times they'll be released from county jails and they won't have any medication. So we're working to try to understand what was happening in the county jails when they were there, trying to bridge medications, trying to re-engage them in the community. So there is an ongoing clinical case management component that our team does as well. But we just struggle because sometimes when they do deteriorate and they do need more, a lot of times they're just not eligible for what is available in the community.
I had a question on that. I think part of the problem here is that jails have become the mental hospitals. There's one mental hospital in Colorado that really takes, especially the most severe. And when we have jails being the mental hospital, the same sort of discharge planning, communications is now put on the jails, which this is ridiculous. This isn't what jails are for. So I think this is a much bigger issue. And I get that my daughter was actually in jail and we saw what the discharge planning looked like. And we saw, I mean, she died a year later. So it didn't work out so well. But this is something where it it's hard when the incarceration, which it should be for mental health, it should be a mental health hold, is instead only because you've committed a crime. Like I can remember when she was getting released and being, gosh, I wish she'd committed a worse crime because she needs to stay in. And this is a much bigger issue, but I'm wondering if there's a way for, and I don't know how that would work, but the DO, but so the Department of Corrections to have more of a say so in things like non-voluntary medication being once they're out. And I don't know how that would be instituted, but that seems like that's a big part of the issue is people are being released way before they should be, because if you're at that level of severity, being put in the community is not good for the person or the community. So this is a much bigger issue, I think, that's going on here. So I'm just wondering, how would you, like, what do you do if it is a non-voluntary medication that's in the jail? Is there any way to get that then non-voluntary once they're out?
I'll let Laura speak to that a little bit, but right now it does not follow them. And, by statute, they have to be released. So it's not like we can hold on to them longer and allow stabilization to take place. When they hit their date, statutorily, we have to release them. We don't have a choice. So we don't have the option of holding on to them a little bit longer until they stabilize. And as far as the process, I guess legally for involuntary medications in facilities is different than the process of involuntary medications in the community setting. And I think that's where the problem lies. And it's not really transferable, I guess. I don't know a better word to say, but Laura, do you have anything else?
I wish I did. I mean, Kelly, you kind of, hit on a struggle that we've really been struggling with for years. I mean, Joy can even speak to this. It is different. Like when someone is on involuntary medications in the prison, it's even worse with the jails. But because they don't even have involuntary medications. But with the prisons with DOC, it is psychiatrists that have placed that order essentially, and so there is no jurisdiction once they leave the prison, and they're under the parole boards. If they're not discharged, then they're under the parole board, supervision and jurisdiction. And we certainly talked to them about, it's on your parole board agreement, you've agreed to follow recommendations and take these medications, but then, it really is up to them. And so, and I think to try and get a civil commitment for medications, going the civil way is a very overwhelming, labor intensive, difficult process. And I think that is a huge challenge. I would like to see how we could try to make that process a little bit easier to embark on. I don't know, Joy, if you have any thoughts about that. I know we've talked about it for years.
Yeah, I think, Kelly, to your point, it is a much bigger problem in that there currently are not involuntary medications in a jail detention setting. And there's a lot of controversy around that. There's like, this perception or a perspective that it's needed, that, people need to get on medication in particularly. And then there's also the perspective of like, it's not a clinical setting when we are offering one of the highest levels of intervention and, starting to impinge on those civil liberties, and jails are not like equipped, built, or intended to provide that level of clinical care. But there's also not necessarily the appetite to have a true diversion center of sorts where it's not a jail. but it's a more secure clinical setting. That's been a discussion that I've been on the fringes of for over a decade. And, the need is there, but how do we get there? And at the same time, it's like to transition from a highly structured incarcerated setting, that's just stressful, period. I mean, the best, most stablest of individuals don't do that well, let alone when you have the clinical needs that some of the folks do. And it's this transition of systems. I mean, we see it when we're trying to divert out of competency system into the civil system. It is clunky. It is not a one for one. And just because they were involuntary medication in the prison system, they were able to meet that threshold with, that system. We're asking the civil system to like take our word for it, as they're leaving, and to then pick up that it's too different. And it's, we're looking at processes and rights and those things, and we know of the best of intentions, it is just clumsy at best. And we keep doing this duct taping of systems. And that is exactly what you were saying, Kelly, that I heard. It's like, this is much bigger than just this. Sorry, that's my soapbox. I've had a lot of passion around this for years.
I may be simplifying this, but I think an easy-ish fix is somehow adjusting federal law, which I know that's real easy, but I think a big piece is there's just not a good way to share information. If, somebody's been at the state hospital for 3 years and then for some reason gets into DOC and then gets released, if the current provider could have all of the information of this person's entire life, they could see that this person has a history of X, Y, and Z and took this long to stabilize and, stabilized on this medication versus, they're at Highlands for a week and that's one setting. And then they go to prison and prison doesn't get the Highlands information. And there's just no good way for every provider that touches on these people to get the whole story. So the providers can only treat long enough to see what they see. And the patient may present as, they may deny that they have suicidal ideation or homicidal ideation, or we may not have accurate information to show that their grave disability is much more imminent than their current presentation. And so they just get released because civil rights say we can't keep patients who don't meet acute inpatient criteria, and insurance won't pay if the patient says they're not suicidal or homicidal and they're good at hiding their symptoms because they want to be homeless on the street. So there's just not a good mechanism for sharing the amount of information it would take to show that historically the patient needs longer and more.
I think another problem that we're up against here too is that we could legislate this all day long, but at the end of the day, you don't have enough providers to meet the need. And at the end of the day, I think that that's a big point that, if you want to put all of these expectations on the system itself, then you need to be able on the back end to open up some funding so that we can meet those needs. I mean, at the end of the day, look, these facilities are understaffed. When you got 2, 3, 5 at the most for almost 2,000 inmates, you can't tell me that anybody's behavioral health needs are being met, let alone your higher acuity. And then you push them out into a community that doesn't have the staff either. Then you're already going in there, being crutched by that whole process.
Yeah, I'll say that, our the psychiatry team at Colorado DOC is in our division, and so we talk a lot about this clinically. I know that's been a challenge for our providers, and we try to think creatively, and it's always feels like it's kind of ad hoc, and duct tape feels like the right analogy to me. I guess I don't disagree with anything that's been said. Just two other thoughts. One is there was a lot of promise, I think, around the waiver for Medicaid funding some services for InReach. And I don't exactly understand. It seems like that's kind of not getting traction or not working as well as we had hoped. And I don't quite, maybe I don't entirely understand why that's the case and what the barriers are. So I wonder if that's also something that, has been a success, that was potentially a success that we could lean into. And then the other question I had for the group is, what is BHA's infrastructure for engaging with DOC? Like, is there a DOC point person at BHA, and what does that look like? And is that an opportunity to partner a little bit?
There's a couple of things, Dr. Simpson. The 1115 waiver is in process, right? I mean, because there's this rollout of sorts of who's going first, and they kind of picked DOC to go first for a couple of different reasons. I'm talking they as in HCPF with the Medicaid, because DOC already had the process in place. Because they had been applying for people's Medicaid prior to release. There's InReach that has been established for years, whether it's psychiatrically, and then of course MAT. So there was already, this robust model that's already in place. And plus with DOC, it's a much clearer picture of a release date. There's either your mandatory release date, parole release date. We have a lot more information. I still say we after these years, but it is, there's a lot clearer picture of like when that client is going to leave the doors of DOC. In the jails, it's much more up in the air and unknown, because we don't know exactly when that will happen or if charges are all of a sudden dropped. I mean, they have to let them go. There's no way to do that. And I think even with the 1115 and efforts, there's that wild card of, when the jails have to release somebody. And even with systems, they just can't, like, let's hold on a second before we do that. And so it's a big challenge with that. I still think it's hopeful for the 1115 will help at least get some things in place sooner than later with transitionary medication that we wouldn't normally get in incarceration settings that could hopefully transition better in the community. My question, because Dr. Simpson, to your point, DOC psychiatry is through the university. And as you're aware, in the Department of Corrections, it's Washington v. Harper. It's an administrative review process around involuntary medications. It is not typically a sole provider that is making the decision around involuntary medication in that environment. Whereas under civil commitment in the community, it is pretty much a sole provider doing that hold, right? Or that long-term certification. Do you think that can make a difference if there was like more of a support around community providers and civil certifications to, help with that burden of sorts? I've always wondered that, because it's like, I wonder if that's some of the concerns is like, I don't see it, we're not doing it, or, whatever that is, and that one provider having that burden.
Well, I guess, it still takes an individual provider on the DOC side, right? They petition and there's a hearing and and you have the infrastructure supporting that provider. Like, I can't just go out in private practice and accept certs. So, I as a provider don't know that I'm super comfortable with the DOC process for involuntary meds governing those meds in the civilian setting. They're just totally different beasts and settings. And so I don't ever foresee that being directly transferable. But but I do feel like there's probably some role has been, as we're hearing here, like, who are those folks? What's the coordination of community mental health? Are the comprehensive mental health centers prepared to at least evaluate for something like a short-term cert? Are courts ready to hear that? Yeah.
I have a slight soapbox moment, so bear with me. It's possible that we can have a system where we have needs to transition people from DOC in a way that's good, to transition people from jail in a way that's good. But those, could be reduced. Those needs could be reduced if we had a mental health system that worked. The burden on DOC and the burden on jails would be lessened. And my sort of hope would be, and especially speaking from the defense side, can't we have a comprehensive solution that allows for the possibility that DOC exists and does have a burden to transition people, et cetera, in jail as well, but also that can be drastically reduced, that burden, if we would focus on another solution, which is our mental health system, and how to make that work in a way that prevents people from needing to be arrested in order to get mental health treatment. And I think I'm just voicing that again, partly on behalf of Kelly too, but also like, I don't want to speak for her at all. But we spend a lot of time talking from the places where we sit, and a solution. I understand there's a solution that needs to happen for DOC when people do get to DOC, and they need these services and jails, as well. But I would hope that there would be a solution that also focused from the Behavioral Health Administration on the mental health system to keep people from needing to go into the criminal system in the first place.
All the while abiding by patient rights and civil rights, that it's legally okay to be psychiatrically unstable and in the community without services, as long as you're not actively hurting yourself or someone else.
I also have an issue with that one because a lot of the most severely mentally ill have anosognosia and have no idea that they're mentally ill. They cannot understand their own illness. And so saying that they have the right to die on the street, I don't know. I have an issue with that.
So we only have about 6 minutes left. The only other thing we had on the agenda today was like what to focus on for the next year. Given some of the things that have come up today, like the competency bill or some of those other pieces of legislation that are coming our way, maybe we can table that for at least the rest of this call, and maybe prioritize that next month. Thoughts?
Yeah, that sounds good. I don't think 5 minutes is enough for that.
No, definitely not. And I'd be very interested to hear what everybody thinks of the competency bill next month. Jen, you want to bring us to a close?
Yeah, any last minute questions, thoughts?
I just want to say thank you, Jen, for having us. We appreciate it. We have just been working to try to figure out how we can do things the best that we can do them with what we have. And so we appreciate your invitation to this meeting.
Yeah,
Thank
thanks
you.
for coming. And this is a public forum, so any other time you're interested or have time, feel free to follow the same link. All right, thank you. Have a good rest of your week.
Thanks, everyone.
Bye.